Yeah.
All right, good morning, everyone. Welcome to Pediatric Round. As always, if you're nearby, please join us in the Mill Mountain Conference Room in the Hanover building. And thank you for joining us online. Please silence your phones. All right, today's speaker is Dr. Anthony Staples from the Department of Pediatric Neurology. Dr. Staples was born and raised in Appomattox, Virginia, and always wanted to remain in Virginia for his career. He completed his undergraduate training at Liberty University in Lynchburg and his medical training at VCOM in Blacksburg, Virginia. He went on to Cleveland Clinic in Ohio for his pediatric neurology residency and developed an interest in sleep medicine. He detoured to Birmingham, Alabama for a fellowship in sleep with a focus on pediatric sleep medicine. He finally returned to Virginia in August of 2021 as a practicing pediatric neurologist and pediatric sleep medicine with Carilion. He is joined locally by his wife and about to be baby number 2. Please join me in welcoming Dr. Anthony Staples.
Thank you, Dr. Farnsworth. Good morning, everybody. Thank you all for having me. I'm going to take off my mask so you can see my face. I'm giving a talk today entitled "Weekends Are Always Such a Headache." A little bit of a spoiler already, but I have no relevant financial disclosures or conflicts of interest. I will be discussing some non-FDA approved use of medication, which is true of every pediatric talk. My goals and objectives today are to review an interesting case, and to not spoil said case quite yet, outline more about the diagnosis of this case, and discuss some controversies and pitfalls in the treatment. So my case starts with a 12-year-old who was being transferred to me for further evaluation of altered mental status. This was somebody I saw in my residency. I put a little mnemonic here that many of us probably learned in medical school, AEIOU tips. It's a good way to start, but you may find out from this presentation that it's not sufficient in some cases. So this patient, 2 days prior to being transferred to me, was a little off, walking out of the house without his shoes or socks on. This is a 12-year-old again, so he should know he should put shoes and socks on. Not talking, just pointing to things. Earlier in the morning, he was able to tell a younger sibling that he was dizzy, but that was the last thing anybody heard him say. He was vomiting, and EMS was called. He was able to walk to the ambulance with assistance. He had fecal incontinence on the way to the hospital, and his left side seemed stronger than his right side. He was agitated at the outside hospital and was medicated and out since then for the parents, with no recent infectious symptoms and no known ingestions. In the other hospital, he had an EEG that reportedly showed some left hemisphere slowing. He had a fever to 101, a lumbar puncture was performed with unremarkable CSF, and he was given levetiracetam, a load, and then started on maintenance dosing for consideration of the post-ictal state. So at this point, could be anything. A little bit more background information. 6 months prior to this, he was also admitted to that other prior hospital with altered mental status, headache, and right-sided weakness. He had a CT and an MRI with and without contrast, which were normal at that time. Again, unremarkable CSF. He was covered with antibiotics and acyclovir and was tested for HSV at that time. His EEG showed some left temporal and posterior slowing. He was thought to have seizures and was treated with levetiracetam and discharged after 4 days. He was then readmitted 2 days after that with, again, confusion and slurred speech. Additional imaging was unremarkable. He was diagnosed with basilar migraine. That's in quotes for a specific reason. And then headache and seizure-free after that time. He was found to have a right retinal lesion, congenital hypertrophy of the pigmented retinal epithelium, which isn't terribly relevant to this case. It is associated with familial adenomatous polyposis, which, to the best of my knowledge, he has not been tested for. He was started into a pyramate at a low dose, and he was discharged after 3 days. Since that 6 months ago period, he had 1 or 2 mild headaches, no vomiting, and was able to carry out his daily activities, no reported seizure-like activity at home. So this is just a brief summary. 6 months ago, altered mental status, treated as seizures. 2 days later, altered mental status, treated as basilar migraine, and now readmitted. Background history: he was born at 34 weeks. There was some maternal tobacco use during pregnancy. He was vigorous per report, but was in the NICU for 1.5 weeks, which seems a little bit long just for some phototherapy, but that's what mom reported. He had normal early development, but then had a lisp in pre-K and some emerging learning difficulties with an IEP for reading and math. He was in the 6th grade at that time and learning at 3rd to 4th grade level. He was diagnosed with ADHD in the 2nd or 3rd grade and previously on methylphenidate, but he's no longer on that, and that might be because he had obstructive sleep apnea and he had his tonsils and adenoids out, and that made things better. He had a learning disability, like we said. He was African American descent. There was no known consanguinity in the family. He did have an 11-year-old brother who was born at 24 weeks with hydrocephalus and a VP shunt, probably not something hereditary, probably more related to prematurity. He had a 7-year-old brother who was completely healthy. There was no family history of headache or migraine, known or suspected genetic conditions, birth defects, seizures, other neurological problems that the family is aware of. So when I first saw him, his vitals were stable. He was arousable to repeated noxious stimulation only. He would open his eyes to pain. He said ouch to pain. He localized pain. If you put him in an uncomfortable position, he would kind of move his body back to a comfortable position. Beyond that, he was not responsive at all and did not follow commands. So if you were doing a GCS, which is not really the purpose of the GCS in this case, but he'd be somewhere around, what is that, an 8, a 10? He would blink to threat. His pupils were going around reactive to light. His face was symmetric. He had an intact oculocephalic reflex, which tests cranial nerves 3, 6, and 8. Normal tone, no posturing, and normal reflexes other than some brisk patellar reflexes with cross-adductor response bilaterally, but those were symmetric. So again, prior workup, normal imaging, normal urine drug screen, EEG showing left greater than right slowing, CSF normal. Then normal imaging again, and again another normal urine drug screen, which I'm realizing now that was 2 days separated for 2 urine drug screens. I guess they really want to rule that out, which is a good thing to rule out. And then during his admission 2 days prior to me, another normal MRI, another normal urine drug screen, EEG again showing left greater than right slowing, normal CSF, and a topiramate level which was low, which does not necessarily mean lack of compliance. He was on low dose for migraine prophylaxis. So this would be the part where if this were a different type of talk, I would ask everybody to think about some differentials, but we're going to move on. So he had some NMDA testing. It was negative. Ammonia was normal. Ceruloplasmin and copper were normal, looking for things like Wilson's disease, which can cause altered mental status. Lactate, also normal, and a negative blood drug screen. We did an additional blood drug screen. Plasma acylcarnitine and amino acids were non-diagnostic. His urine organic acids showed some ketonuria, but he had been altered for a couple of days and was essentially NPO, so that wasn't too unexpected. Those were repeated later, and there was no significant ketonuria. We did some testing through Mayo Clinic for porphyrias, and that was normal as well. We also sent an autoimmune encephalopathy panel through Mayo Clinic, and also did some genetic testing, which we'll talk about in a second. So forgive me for showing some of my neurology squiggly lines, but the purpose of this talk is not to teach anybody how to read an EEG. That's a 3-month talk. But I hope everybody can see that there's some difference here and here as compared to here and here. These first 4 are the left, these next 4 are the right, then the left, then the right. You can see that it's slower on the left than the right. This patient's probably asleep, so the right may be a little slow as well, or just sleep, but the left is clearly asymmetric. That was at the beginning of his admission. As we progress, same thing, left, right, left, right. Look over here, you can see it's definitely slower still on the left. These are eye blinks, don't worry about that. And then near the time of discharge, again, slower on the left than the right. That's a very non-specific finding. That just means that the left side is not working like the right side is. That doesn't show epileptiform discharges. That doesn't mean he had a seizure. It could be postictal. It could be one of a million things. So over time, while admitted, his mental status improved. He was walking the hallways, responding to questions, but unable to answer what he ate for breakfast and unable to follow complex directions. He had a brief trial of verapamil, 80 milligrams with asymptomatic bradycardia. The cardiologist saw him at that time, and they were fine with him being sent home on that. But the bradycardia was kind of in the 40s, and he was 12, and as the neurology team, we decided nah. And he was discharged after 3 days, again onto a pyramate, a little bit different dosing. And I will tell you that as the last time I saw him, which was a couple years ago, he had been transitioned to acetazolamide because of some ongoing issues, not quite as bad as this. So testing returned back, autoimmune encephalopathy panel was negative, but he was found to have a pathogenic variant, an ATP1A2, a threonine to methionine missense mutation at position 367. consistent with familial hemiplegic migraine. And this is a part of the talk where people go, why am I learning about this thing I'm never going to see? And I will say that thankfully, even after this talk was already made and ready to go, within the last month, I had somebody admitted with altered mental status, fever, strong family history of complicated migraine, no weakness, but started with right-sided tingling, and then just became completely altered. For 2 days, got all better, did almost all the exact same tests. They were all negative. We did not do the genetic testing because they do not live locally. We said you can pursue that with your home folks. So you might see this. And so let's move on to the ICHD3. This is readily available online. You do not have to have a membership. You just type in ICHD3 in Google and this will come up. This is the International Classification of Headaches Disorders 3. Just to kind of get an idea of some of the definitions of headaches. So migraine without aura requires at least 5 attacks. Because it doesn't have aura, it requires a few more attacks to be sure that that's what you're dealing with. The headaches are typically 4 to 72 hours, not true in kids always, and that's specifically untreated or unsuccessfully treated. If you treat it and it goes away quicker, that doesn't rule it out. Kids can be a little bit shorter. Usually, it's unilateral, also not as true in kids, pulsating quality or throbbing, moderate or severe pain, and aggravated by routine physical activity. This is the one that tricks a lot of people up, and often I have to tell my patients that you don't technically have migraine. You have to have at least one of the following: nausea and or vomiting. So just nausea alone with these other criteria gives you migraine. But if you don't have either of those, you have to have photophobia and phonophobia. The number of people I've seen that don't have any nausea, don't have any vomiting, have photophobia, but don't have any phonophobia is, I would say, 50% of my patients with headaches. So it's not uncommon that they don't technically meet the criteria for migraine. And like we said, there's a few caveats. In pediatric patients, the headache may be a little bit shorter. It's more often bilateral. It's very rarely occipital. You have to think about other things if it's purely an occipital headache. And photophobia and phonophobia in the younger kids often has to be inferred. Your 5-year-olds don't usually go to a quiet, dark room to lie down in the middle of the day. If they're doing that, that could mean that there's some photophobia and phonophobia. Migraine with aura, since it's a little bit more specific of a diagnosis, you have the aura beforehand, only requires 2 attacks, with 1 or more of the following fully reversible aura symptoms: visual, which is the most common, sensory, speech or language, motor, which is rare, but we're going to talk a lot more about that, brainstem, and retinal. Generally, to differentiate this from an ischemic injury is usually rapid onset, seconds. If they're having migraine aura, a couple of things. Often there's a positive phenomenon, so like with visual aura, you often have like the scintillating symptomas and bright lights and things like that, as opposed to pure vision loss. Not always, but you can. And then also, it's sometimes hard for them to describe this, but it generally changes over minutes. In fact, that patient I was talking about a month ago, he was able to explain to his parents before he became altered, and then he didn't remember after he woke up, that it seemed like his sensory changes progressed up his hand slowly over time, up to his shoulder, then to his foot, up his leg, and then to the right side of his face. If it takes minutes, it's probably not an ischemic injury, although you need to rule that out as well in cases like this. So the most common aura in migraine with aura is a visual aura, which is present in most patients with this, and most have a fortification spectrum. This is actually a artist's representation of their migraine visual aura. You can see dots, spots, colors, lines, scintillations, and blurred vision. Sensory pins and needles are also common, and less frequently, speech. The typical aura is usually fully reversible. If there's no headache within 60 minutes of the aura, it can be considered without headache, or migraine hemicrania. Let's go back real quick. You can see that at least 3 of the following 6 characteristics must be here. And one of those 6 is the aura is accompanied by or followed within 60 minutes by headache. But if you have at least 3 of the other ones, you don't necessarily have to have a headache to have migraine with aura. Although, again, I would use a little bit more caution to assume something's a migraine aura if you're not having headaches. The aura, more recently, we're going to talk about some controversy soon, is thought to be caused by a cortical spray in depression, which is a brief neuronal excitation that kind of self-propagates in a depolarization wave, leaving prolonged inhibition of neuronal activity in its wake that can cause pain and aura. Moving on to migraine with brainstem aura, which is why I put basilar migraine in quotations. That is the old name. The new preferred name is migraine with brainstem aura. This is, again, migraine with aura, meeting those criteria. You have to have specific type of aura symptoms, at least two of the following. So dysarthria, vertigo, tinnitus, hearing issues, diplopia, ataxia, and the one that I want to highlight here, decreased level of consciousness, a GCS of less than or equal to 13. And these patients cannot have motor or retinal symptoms. The reason they cannot is because if they have motor symptoms, they now have hemiplegic migraine. If you have true weakness, that's hemiplegic migraine. It should be fully reversible motor weakness, but these patients also should have or have to have a separate aura symptom, visual, sensory, and or speech language symptoms. Sometimes the patient's significantly altered. They may not remember that, and they may not be able to describe that. Although if you remember with our patient, he stopped talking, and then he became weak. So we can kind of infer that. The term plegic means paralysis. These are more paretic. They usually do not have complete paralysis. They usually have weakness. What's important to note, and I have underlined in red here, is we talked about aura symptoms generally go away quickly. Motor symptoms in hemiplegic migraine can last typically less than 72 hours, which I don't think anybody would consider quick. And some patients can persist for weeks. I'm not going to belabor this one too much. This is the syndrome of transient headache and neurological deficits with cerebrospinal fluid lymphocytosis, which we're going to call handle for the rest of this visit for the obvious reasons. And this can present very similar to hemiplegic migraine, but this is a self-limited condition that is caused by lymphocytosis, possibly autoimmune, and goes away after 3 months without treatment. Whereas people who have hemiplegic migraine can continue to have attacks throughout the course of their life. So let's get into hemiplegic migraine specifically. And again, I'm getting ready to tell you that this is very rare. Migraine occurs in about 15 to 20% of the population, but hemiplegic migraine is rare with a reported prevalence of about 0.01%. Women are 3 times more likely to be affected than men. So you're again wondering, why am I talking about this? And what prompted me to give this talk was I've had at least, and I've only been here since August, at least 6 unique patients with hemiplegic migraine already. And I think I've had 7. I didn't go back through my list to confirm that. So we're going to say at least 6. So this is something you're going to see. So when it comes to genetic changes in hemiplegic migraine, you can think of 2 different types, and also just in hemiplegic migraine in general. Familial, which has 3 different types, 1, 2, and 3. So familial hemiplegic migraine 1, 2, and 3. We're going to call FHM 1, 2, and 3 from now on. 1 is due to CACNA1A gene mutations. 2 is due to ATP1A2 gene mutations, which is what our patient had. And 3 is due to SCN1A gene mutations. Then there are some others that are emerging. What differentiates familial from sporadic is not a gene mutation. You can have the exact same gene mutation, but if you don't have any family history, it's considered sporadic. And so technically, our patient would have sporadic hemiplegic migraine, because to the best of their knowledge, there was no prior family history. At the time I left, I can't recall, but I do not think testing was back for parental testing to see if it was actually carried with incomplete penetrance by one of the parents. So familial hemiplegic migraine was actually first described in 1910 by Clark. He described attacks of hemianopia, loss of speech, and hemiplegia in a family. You can see here that this is an old chart, but anything in bold text is somebody who's affected. And 100% of the kids in this group were affected. Neither of these people were affected. You have to assume that wasn't sporadic. One of these probably carried a mutation, possibly did not have symptoms because of incomplete penetrance. Because familial hemiplegic migraine is passed on in an autosomal dominant fashion. There's about 80% penetrance, so it could happen that they had incomplete penetrance in that family. There's numerous proposed phenotype and genotype correlations. The attacks are typically triggered by normal headache triggers, but one that's really important to realize is minor head trauma can cause issues, and including, you'll hear in a few minutes here, prolonged coma with minor head trauma, and even recurrent strokes with minor head trauma. I have a little picture here of other things, fatigue, stress, hormonal changes, smells, food, alcohol, sleep disturbances, which is near and dear to my heart. All can be triggers of migraine. So these patients who have a genetic change generally have earlier onset of migraine with a mean of 11.7 years. So these are patients we will detect. We may not come to the diagnosis immediately, but these patients will appear in our clinics. These attacks tend to decrease with age. The neurological deficits can last hours to days, and impaired consciousness up to coma and encephalopathy can be seen in about 21% of patients with genetic changes. Rarely, patients will have persistent attention and memory issues for weeks to months. Like we talked about with our patient, they had some baseline ADHD and learning difficulties, but definitely seemed like they were having more attention issues for at least a few months, and then I graduated, so I don't know, but at least a few months after their presentation to me. Motor aura is always associated with at least one other aura symptom, like we said, and typically it progresses in succession. Typically, you first have visual aura, then sensory aura, then motor, then aphasic, and then basilar. And the sensory aura tends to be in the same location as the subsequent motor aura. And often, it is more common in the hand and arm, and then progresses to the foot, and then involves the face, almost like my patient a month ago read the textbook before they came in. That's a working diagnosis still. Once this has only happened once, you don't want to assume. So dysphagia is common with right-sided weakness. Imaging is usually normal, although those with familial hemiplegic migraine 1 can have some cerebellar Vermean atrophy. And then there can be rare transient changes of cytotoxic edema. And then they can also have atrophy contralateral to the hemiparesis in those who've had a lot of severe attacks. EEG, like our patient did, can show asymmetric slowing in the delta range of the affected hemisphere. It usually improves following attacks, but may remain abnormal. And I will say that some of these patients have increased risk of seizures as well, which causes a little bit of trouble. Rarely, this has been associated in the literature with infarction and death, but really you should be considering alternatives if you see infarction on imaging. The differential is obviously broad, and I've chosen some of the more esoteric neurological things to highlight here, but things like MELAS, CADASIL, which is cerebral autosomal dominant arteriopathy with subcortical imparts, and leukoencephalopathy. Some of the more common things, tumor and mass, alternating hemiplegia of childhood is something to be aware of. Seizures, TIA, stroke, SMART, which is stroke-like migraine attack after radiation therapy. Really, the differentiation there is a history of radiation therapy. Those patients also tend to have cortical edema, but we just said that hemiplegic migraine patients can as well, so it's kind of hard to differentiate in that sense. And then we talked about handle before as well. So looking specifically at each genetic change, familial hemiplegic migraine 1 is due to CACNA1A gene mutations found on chromosome 19p1313. This makes up about 7% of familial hemiplegic migraine, and generally is made up of missense mutations. To remind folks, because it's been a while that many of us have done genetics, missense mutations cause one amino acid to be changed to another inside of the protein. 40 to 50% of these patients will have cerebellar signs, some of them permanent cerebellar signs, nystagmus and progressive ataxia, and they can have some Vermean and cerebellar atrophy, which is pictured here in this sagittal MRI. This is a cerebellar vermix, and it should be a little bit more plump than that. So 10% of family members with this gene mutation will have migraine with or without aura, without hemiplegia. There are reports of coma, fever, and meningismus, and sometimes this can last for weeks. And some patients have attacks of paranoid psychosis and visual hallucinations, and some have prolonged and persistent cognitive impairment. One group, Dr. Trent, who shows up a lot in hemiplegic migraine literature, looked at 27 patients with sporadic hemiplegic migraine, so no family history of hemiplegic migraine, and they were looking for CACNA1A gene mutations. This was a little bit older, so in 2002, so there may be other ones that could be changed in criteria now, but they only found 2 that had a CACNA1A gene mutation, one of whom had cerebellar ataxia and atrophy. I circled a couple other things here. A couple of these patients had unconsciousness during their attacks, just like ours. And then you can see that the duration of the symptoms were highly variable in this 27-person group. 15 to 60 minutes, 2 days to 1 week, 1 week to 1 month. I will highlight there's also a person who had a duration of 0 with frequency attacks question marks, so take with that what you will. If I had hemiplegic migraine, I'd rather mine last 0 as well. So this CACNA1A gene mutation is 47 exons spanning 300 kilobase pairs. Exon 47 contains a polymorphic CAG repeat, which for board purposes should be ringing a little bell for CAG repeat disorders like Huntington's disease and spinocerebellar ataxia. It encodes the alpha-1 subunit of the neural voltage-gated PQ-type calcium channel, which is involved in synaptic transmission. The thought that is that a gain-of-function mutation causes an enhanced excitatory neurotransmission, causing familial hemiplegic migraine. This is an artist's representation of the protein. It's a transmembrane protein. And on this particular representation, they have in red some of the places where amino acids can be changed and associated with familial hemiplegic migraine. In green, episodic ataxia. Paroxysmal tonic upward gaze is here, and a single patient had Lennox-Gastaut syndrome. So all three of these genes we're going to talk about today are associated with other allelic disorders that like to pop up in neurology, including in CACNA1A, episodic ataxia type 2. We said that in hemiplegic migraine, it's missense mutations. This tends to be bigger non-sense frame shift, splice site, or multi-exon deletion mutations, so bigger changes in the gene. And this causes episodes of ataxia, sometimes with migraine, some with hemiplegia and nystagmus. Spinocerebellar ataxia type 6 is a CAG repeat expansion, like we just talked about. They tend to have late onset progressive ataxia and can have migraines. And there are some people with CACNA1A gene mutations who have been known to have delayed fatal cerebral edema and coma after mild head trauma. I found a case report of a patient who was 6 years old with multiple ischemic strokes each time after minor head trauma. He was found to have a novel likely gain-of-function mutation in CACNA1A. Actually, she was. And after starting verapamil, which is a calcium channel blocker, and this is a calcium channelopathy, she had no additional strokes despite recurrent head trauma at the time of this publication. So moving on to familial hemiplegic migraine 2, which is due to ATP1A2 gene mutations. And all of these things are coming from OMIM. OMIM is the online Mendelian inheritance model or manual, and it's a great resource for genetic conditions. Chromosome 1q23.2. This again makes up 7% of familial hemiplegic migraine. These patients have a higher risk for seizures during severe attacks, and some with seizures and learning difficulties outside of attacks. Again, they can have recurrent coma lasting days to weeks. Some of these patients will have fever. My patient a month ago had fever. My patient that I'm presenting today also had fever. Those with confirmed mutations tend to have more severe attacks. And some have had progressive hearing loss as well, which are seen specifically in a Carilion family with the gene mutation in ATP1A2. After doing a lot of digging, I was actually able to find the initial description of the exact gene mutation of my patient. And it was described initially in a Portuguese family with pure familial hemiplegic migraine. On this chart, anybody that has a blacked out portion in the lower half is affected by hemiplegic migraine. Upper right quadrant there is somebody who has migraine but without hemiplegia. All but one of these had normal physical, cognitive, and social development. And they found in these patients that the mutation caused a decreased protein function. So familial hemiplegic migraine 1, gain of function, 2, loss of function. So ATP1A2 spans 23 exons, 25 kilobase pairs. Here's another artist representation of the protein. You can see that there are a bunch of different places on this protein that can cause familial hemiplegic migraine, basilar migraine, and then there's even some alternating hemiplegia of childhood, which you mentioned earlier. This encodes a transmembrane sodium-potassium ATPase, and we said it's a loss of function mutation that causes issues for familial hemiplegic migraine. So an allelic disorder that I want to highlight was alternating hemiplegia of childhood, which is more commonly seen with ATP1A3 pathogenic variants, but can be seen in ATP1A2 as well. It tends to have an onset before 18 months with transient minutes to weeks of hemiplegia, with dystonia, oculomotor abnormalities, and autonomic phenomenon. These patients have a disappearance of symptoms of sleep. They often have ongoing developmental delay, chorioathetosis, dystonia, and ataxia, and a risk of status epilepticus, and they too can have headaches. Moving on to 3, SCN1A gene mutations. I don't know how much that shows up for everybody else, but in neurology, that's a big one, and we'll talk about that in a second. This is an unknown portion of the familial hemiplegic migraine. Some of these patients can have elicited repetitive daily blindness, which is actually very interesting. On orthostasis or change in light intensity or even mild pressure to the eye, they'll have brief periods of blindness. And this is thought to represent retinal spreading depression. We talked about cortical spreading depression causing migraine with aura. This is thought to be retinal spreading depression. So SCN1A is 26 exons over 82 kilobase pairs. This is a very pixelated, sadly, artist representation of the protein. It encodes the voltage-sensing ion-conducting alpha-1 subunit of a neural voltage-dependent sodium channel. I hope everybody can see the trend here. These are all transmembrane channels. Familial hemiplegic migraine 3 is caused by mutations that accelerate fast recovery and activation of recovery from fast inactivation of sodium channel. So this is a gain of function mutation. Gain, loss, gain for 1, 2, and 3. So this is associated with a lot of different things, including febrile seizures, all the way up to generalized epilepsy with febrile seizures plus, and Dravet syndrome, which is a spectrum of disorders, and Dravet syndrome being the most severe, often with severe outcomes in development as well, and hard to control seizures. These patients can also have myoclonic astatic epilepsy if they have changes in other portions of the gene. This was known as Deuce syndrome, infantile spasms, and Lennox-Gastaut syndrome. So a lot of bad epilepsy subtypes also come with SCN1A. I'm not going to do this slide too much. I'll leave it up there for folks a little bit, but this is just a reiteration of what I've talked about. CACNA1A, ATP1A2, SCN1A. Penetrance tends to be around 80%. Here they list SCN1A as 100% penetrance in familial hemiplegic migraine. In large families, the male to female ratio is 1:1. In the general population, hemiplegic migraine is more common in women with these gene mutations. You can see that age of onset is about 12 years, 11 years, 13 years. With additional cerebellar signs, 26 years with the familial hemiplegic migraine 2, as opposed to 12 here. And down here, I wanted to highlight the number of attacks. So to go back to the case a month ago, which was not planned for this, we did not start a preventative medication. One, because this is a provisional diagnosis. This child has had 1 attack. He doesn't have any other headaches. And some of these patients have 1 attack their entire life. And I'd feel real bad treating somebody with a medication with side effects for years if that was the only attack they're ever going to have. But some have hundreds. And as you can imagine, these attacks are very disruptive to their life. This child I presented today had been admitted 3 times, multiple times requiring IV fluids, requiring NG tube placement for feeds, because he could not maintain his status. So even if they're infrequent, sometimes you need to consider treating. So how do these gene mutations cause this? The thought is they cause an increased susceptibility to cortical-sparing depression through cortical excitability, specifically through glutamate. So like we said, familial hemiplegic migraine 1, a gain of function mutation, causes excessive synaptic glutamate. Familial hemiplegic migraine 2, a loss of function mutation. So if, remember, sodium, potassium, ATPases are meant to push sodium out of the cell and remove and bring potassium back into the cell. By having a loss of function mutation, we have decreasing removal of potassium and glutamate from the synaptic cleft. And then familial hemiplegic migraine 3, a gain of function mutation causes excessive extracellular potassium, which again leads to more glutamate. And this is demonstrated here. There is not officially, as of the time I looked at the website, and maybe as of today that's changed, but familial hemiplegic migraine 4. But there are some candidates. One possible linkage is to CACNA1E, which is only different from CACNA1A in this last letter, so it's another calcium channel. But the more favored candidate is PRRT2, which is associated with paroxysmal kinesogenic dyskinesia, which is a mouthful, but it's actually pretty easy. It's dyskinesia that happens randomly when you move, and it's with or without infantile convulsions, or episodic ataxia. And they actually looked at a group of patients with PRRT2 gene mutations. Most of these had, actually I think all of them, almost all of them had paroxysmal kinesogenic dyskinesia. Underlined in blue, you can see the ones that also had migraine, and circled in red, you can see the ones that had hemiplegic migraine in this group. And this one also had seizures. And some other ones had seizures as well in this group. So, should you have an altered mental status patient with fever and think, oh, this is probably hemiplegic migraine presentation? The answer is absolutely not, never, never, never. And should you have a patient who has unilateral weakness and a headache and assume this is hemiplegic migraine at the first presentation? Also no. It's important to do a broad initial workup for these patients. Genetic testing and panels exist, as we did with this patient. That is not the first step. Those take weeks to come back, and many patients won't need that either. Our patient got it because he had such a severe attack. We really wanted to get to the bottom of what was causing this. But you should get imaging, in my opinion. I would consider hemiplegic migraine on initial presentation a diagnosis of exclusion. When you're talking about adult stroke, the process is get a CT to rule out bleed, assume it's a stroke. In peds, it's different. There's so many other diagnoses, and stroke is not as common, although you do see it. So instead of ruling out a bleed, you have to rule in a stroke, and that requires MRI. You need to be able to look for diffusion restriction, which shows up within minutes of ischemic injury, as opposed to CT changes, which take hours to days to show up in ischemic injury. So generally, I'd recommend an MRI. MRI in familial hemiplegic migraine, like I said, can show cerebral edema with swelling of a cortical ribbon and cerebellar atrophy, especially in familial hemiplegic migraine 1, during attacks. Between attacks, usually the parenchyma is normal, but again, you can still have cerebellar atrophy. Traditional angiography is not recommended. We'll talk about that in a second, but if you do MRA or CTA, you have to understand, has a lot of radiation. So if you're doing an MRI, you might as well do the MRA right there. But you can see vasoconstriction or vasodilation during the attack. Between it's typically normal. Transcranial Doppler during the attack can show diffuse or localized increase in intracranial velocities, which would be associated with the vasomotor changes there. And in between attacks is normal. EEG, like we said, can show slowing on the affected side. Sometimes these patients have seizures, so they can have sharp waves or even subclinical seizures or clinical seizures. In between, it can be normal, or if there's somebody who has seizures, abnormal. CSF, to complicate things slightly, can show elevated white blood cells. So now you have a patient who's altered mental status, fever, and elevated white blood cells in the CSF. That's kind of tough. Usually in around 12 to 290 white blood cells, and it's usually lymphocytes. So we talked about handle, which is lymphocytes, hemiplegic migraine goes away in 3 months. Now we're talking about hemiplegic migraine, which is lymphocytes, hemiplegic migraine doesn't go away in 3 months. So differentiating those in the acute phase is very difficult. Protein can be elevated. Usually you have normal glucose concentrations. Between attacks, CSF should be normal. So what's the treatment? And I will tell you that absolutely none of this is FDA approved for hemiplegic migraine. And most of this is at best case series level and more case report level evidence. Acetazolamide is thought to be especially helpful with familial hemiplegic migraine 1 and 2. And like we said, my patient, we switched from topiramate to acetazolamide after some ongoing minor issues before I left my residency. The reason we started with topiramate was cover seizures, although not at that dose. And also topiramate is fun because it has carbonic anhydrase inhibitor activity as well, as does anisimide, so it has a little bit of overlap with acetazolamide. Other traditional migraine prophylactic medicines have been tried. TCAs, amitriptyline. Beta blockers are controversial because there's concerns about limiting the compensatory vasodilation, and some experts recommend avoiding that. We're going to get into that a little bit more later. Calcium channel blockers such as verapamil, especially in people who have a gain of function calcium channelopathy, makes sense, mechanistically at least. And then certain anti-seizure medicines like topiramate, lacosamide, levetiracetam, and valproate. Of course, if these patients also have seizures, they get anti-seizure medicines. That's what they need for that. And if you can choose one that may help with the headache side of things as well, that's always good. These are all that I've talked about so far to prevent these attacks. And that should be our goal, right? Once the attack has happened, if they're in coma, that's too late. You missed the boat. But there's limited case report evidence for hypertonic saline and glucocorticoids to help abort severe attacks. I'm talking just a couple cases here. These things do self-resolve. It's hard to know whether or not this is effective, but there is some case report evidence. And then there are also some case report evidence of nasal ketamine. As you know, ketamine is an NMDA receptor antagonist, and we think that glutamate, which acts on NMDA receptors, is the cause of the cortical spray and depression in familial hemiplegic migraine. So again, mechanistically, it makes sense that perhaps ketamine would help during an acute attack. as a non-intensivist, the idea of giving a child ketamine gives me a little pause. Generally, it's recommended to avoid vasoconstricting agents. This is where another reason why I wanted to give this talk. So there's a controversial risk of stroke in these patients. So this is based on the old hypothesis of neurologic symptoms of migraines being due to the vascular theory, which is vasoconstriction followed by vasodilation and release of peptides and pain. So if it starts with vasoconstriction, you give something that vasoconstricts, can you overconstrict and lead to a risk of ischemic injury? And this actually includes triptans, like sumatriptan and other medicines, which are very commonly given for migraine. And ergotamines. The ergotamine that's most commonly given, and I do not love this medicine at all, is dihydroergotamine for prolonged migraine attacks. I find that more patients than not get nauseous and crushing substernal chest pain and improvement in headache when I give that, but experience may vary. So what about triptans? Triptans are vasoconstrictive. They work on serotonin receptors. They result in cranial vessel constriction, and they inhibit pro-inflammatory neuropeptide release. So they have historically been contraindicated in patients who have retinal migraine, hemiplegic migraine, or migraine with brainstem aura. And they were actually, patients with those issues were excluded from clinical trials due to the risk, the theoretical risk of stroke. And you'll see this is actually screen captured right from the FDA insert for sumatriptan. Contraindications, history of stroke, TIA, or hemiplegic or basilar migraine. That again is based on the old theory of migraine, which is vascular, as opposed to the more emerging theory, which is it's due to cortical spray and depression. So some groups have looked at this. This group here looked at people with basilar migraine, now migraine with brainstem aura, with 13 patients who received triptans. There's a retrospective review, and their outcome was excellent, with no adverse events. And then another group looked at hemiplegic migraine with triptans, and they looked at 76 patients retrospectively who used triptans on average 257.2 occasions, and none had ischemic stroke or heart attack. One had prolonged neurological symptoms after the use of triptans. Again, is that causative? It's hard to say. And their conclusion was that triptans are probably safe and effective. I don't know if I have the right answer for you, and I will tell you what I tell my patients, which is the FDA says it's contraindicated. Most of them tell me that triptan doesn't make it stop at the beginning anyway, so I generally say, let's try alternatives for now. There's emerging research that maybe we can try triptan again in the future, but I generally recommend avoiding triptans and dihydroergotamine at this point in people with hemiplegic migraine. We also recommend avoiding cerebral angiography, which can lead to a severe attack. And then we talked about exertion, or not exertion as much as minor head trauma leading to significant attacks. So exertion is thought to lead to hyperventilation, which causes hypocapnia, and then respiratory alkalosis with hypomagnesemia, which can cause vasoconstriction and cortical spray depression. So it's important for these patients to be aware. I often have families talk to me about sports and epilepsy, and I say, I'm never going to tell you can't do something, but if getting hit in the head is a planned part of the sport, it might not be a good thing. And if you're playing football and you're not getting hit in the head, you're doing it wrong. And that's true for people with familial hemiplegic migraine as well. I wouldn't recommend rugby or football for these people. Another caution is based on a single case report, so again, take this with a grain of salt, with potential worsening with intravenous nimodipine. This was a 16-year-old patient who had ATP1AT2 gene mutation, who received nimodipine, and then very soon after had worsening of symptoms and a generalized tonic-clonic seizure. Again, was this causative? It's hard to say. Their theory was that there was possible worsening of arterial hypotension. You can see here that the T2 weighted MRI for this patient showed swelling of the gray matter in this area on the right. Again, causation is not clearly established. And we have a couple more seconds. So, a little bonus round for you guys. I have a 17-year-old female with an aura of shimmering lights, or right hand and arm numbness, sometimes with 4 hours of headache and sometimes alone. Her mother was diagnosed with migraine with aura, onset at 45 years old, with abnormal white matter. And her maternal grandmother had early onset strokes. This young lady had some imaging. You can see the abnormalities on the T2, but what's nice about FLAIR is it makes the abnormalities better. So differentiate T2 and FLAIR. T2 CSF is bright. FLAIR attenuates that so that you can look for bright things against a dark background. And you can see that there are some bright areas here and here and here. I will say that I like calling them unidentified bright objects, UBOs, are common in migraine, and they can be small and scattered, and that might not mean anything. But these are a little bit bigger and more confluent than you would easily say, oh, that kid just has migraines, they're fine. So this patient actually had genetic testing and was found to have codicil, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, which now you know why I call it codicil, which is due to Notch3 gene pathogenic variants. These patients have adult onset, usually of migraines, subcortical infarcts, and dementia. And up to 56% will have atypical migraine, including hemiplegic migraine. And I have a couple questions, and I guess, Vicki, you can help me if somebody does inside a chat. So, a mutation in which of the following genes is known to cause hemiplegic migraine? B. I heard a lot of B's, and that's correct. Briefly, what are the other genes? P10. P10 is a gene that's important for people to recognize, especially those who will be seeing children with behavioral issues or autism. If an autistic child has significant macrocephaly, not just right above the curve, but significant macrocephaly, they deserve P10 gene mutations analysis because P10 is associated with numerous different cancers, and they have different cancer screening recommendations. So that is something that's important to know about and be aware of. ACVR1 is associated with fibrodysplasia ossificans progressiva. Not gonna see a lot of that, although I will say I saw it 2 weeks ago. So I don't know, I'm a magnet for weirdness, I guess, but it does come around. AGLAN5 is a gene, but the gene creates a protein, as do most genes. Certain genetic changes can cause issues, but what's interesting about this one is an autoimmune condition with antibodies against the protein is associated with various symptoms, and the ones that are more interesting to me are the acute onset of parasomnias and sleep-disordered breathing. And how does an autoimmune condition cause sleep-disordered breathing, specifically obstructive apnea? I'm not too sure, but we found that it's true. Hopefully this one is an easy one. Per its FDA insert, which of the following classes of medications is contraindicated in hemiplegic migraine? Antihistamines, anticonvulsants, anxiolytics, or triptans? I heard a lot of D's, and that is correct. And if anybody has any questions, I'd be happy to try my best to answer them. Dr. Keys?
Thanks. This is a great talk. I'm curious about the EEG findings.
Yes.
And maybe this is just a blip in my memory, but with other migraine variant or migraine disorders, do you have EEG findings?
I can't say I can answer that for sure. I think not generally, but we also don't generally do an EEG during a migraine attack in people unless they're having altered mental status and things like that. So I have to look into the research a little bit more, but not that I'm aware of.
Yeah, I'm just trying to think. I mean, I've seen this disorder before, being an inpatient physician, and I don't remember the EEG findings in cases. And surely we would have gotten an EEG if they have hemiplegia.
Yeah.
So that was interesting to me.
And again, the patient who miraculously appeared a month ago to help me sell this a little bit better also had the sensory changes, and he had continuous slowing on the left-hand side on his EEG as well. So it definitely can happen. And that's a very non-specific finding. Again, when you're looking at an EEG report, slowing is non-specific. Continuous slowing suggests a structural abnormality, and somebody who has continuous slowing in a specific region deserves an MRI. Oftentimes, you're looking more for a developmental dysplasia or a developmental change, but that could be a tumor as well, so that's why they deserve an MRI. But it's still non-specific, whereas epileptiform discharges are a little bit more specific and point towards seizure, post-ictal, those types of things. Any other questions? Yes, Dr. Tomas.
In patients with SCN1 mutation, is there any component of any clinical component of effect on respiratory drive?
Not that I came across in the literature, but not that I'm aware of. Anybody else? Anybody have questions?
Maybe you could clarify for me, with the vasoconstriction, did you say then that used to be the theory behind migraines or behind just hemiplegic and now it's not?
Behind both.
Behind both.
And used to is a strong word. I think that both theories are still considered, but there's emerging evidence that the cortical spray depression is probably more likely to be the true causative factor. And maybe we don't have to be as careful with the triptans, but again, my current practice is I don't recommend triptans in these patients because all somebody needs to do is pull up the FDA insert and they'll go, this doctor gave me triptans. And so I choose not to at this point. Anything else? Anything online? No? Thank you all so much for having me.